and we are going to be talking about the knee today. We're going to start at the very top, again, where the femur comes down, forms the upper bone of the knee joint, the tibia and the fibula forming the two lower bones of the joint line. Central joint line on Christine right here in the middle. You got the medial joint line, the inside, and the lateral joint line, and the patella bone on top of it, the kneecap. So some of the common patterns. On the medial joint line, of course, the classic medial meniscal tear or medial meniscal pain pattern. You'll feel a tenderness right along the joint line. It's easy to palpate your way up. At the end of the femur, there'll be a little bit of a dip in the beginning of the tibia, the bone below it. And that's where that meniscus sits, and you can only touch those very lateral fibers. But you'll find if the medial meniscus has been injured and the knee's even swollen a little bit, or even not swollen, but the meniscus, but when you stand on it, you feel pain, you're going to notice that this tenderness is on the outside here, and you'll probably be dealing with a medial meniscal problem. On the lateral side is the lateral meniscus, not often injured, but the same pattern exists where if you palpate at the end of the femur, beginning of the tibia, you'll see that the lateral joint line can be palpated. On the inside of the joint line is the anterior cruciate ligament, which starts at the top of your femur and heads down to the tibial plateau, okay, the top of the tibial bone. And that one's oftentimes injured in various sports, twisting sports, skiing. That will be an inside joint pain. You'll notice a lot of swelling on that one if you rupture or damage the ACL. The posterior cruciate ligaments behind it, a cruciate referring to the X shape of the two as they cross each other in the middle of that joint line. And the posterior cruciate ligament sometimes could be injured in a hyperextension injury when the knee goes up quickly past straight, so the back side, where the anterior cruciate ligament is going to get injured a lot of times when the femur rides up and over the tibia, when there's a translational problem here between the upper bone and the lower bone. You got the patella on the top, the kneecap. The bottom side of the patella, or the underside of the patella, has nice smooth cartilage. It sits in the groove of the femur, and that patella can dislocate. Generally, it would be popping laterally or popping to the outside. And we can talk about the iliotibial band on the outside as well, where the iliotibial band is starting from muscles in the hip region here, glute medius and minimus, tensor fasciae lata, forming the lateral side of that band, which comes on down to the lateral side of the knee. And I'll use this leg because it's better. And on the outside of that knee, the iliotibial band will come down and form some fibers and aponeurosis, actually, that cuts across and will attach to the outside of the patella bone, the kneecap. And those are the basic main structures. The neurology of it would be the femoral nerve coming from your low back that will feed the front portion, the quadricep group, so that would straighten the leg out. Or the sciatic nerve and some of the fibers off of the primary roots would be L4, L5, S1 coming down to feed the hamstring on the back to pull the leg downward. Another interesting feature of the knee would be on the back side. On the back side, we have a muscle called popliteal, or the popliteus muscle. It's a muscle that helps the knee to rotate, called the screw home mechanism. So the knee isn't a simple hinge joint. There's a bit of rotation that takes place where the lateral meniscus is fixed and the medial meniscus allows rotation about 15 degrees. So when you're flexing and extending your knee, the knee is actually rotating a little bit. And that medial meniscus, you'll see in the picture there, is more oblong, whereas the lateral one's circular. So the rotation point's that circular lateral side. And then the femur and the tibia are articulating with each other in a very nuanced way for that 15 degrees of screw home mechanism. That's not often a problem, but it's an interesting thing to note. Patellar tendon and bursal sacs as well on the front side. Sometimes there's some bursal sacs that can be aggravated. A few of them lie under the iliotibial band here. A few of them lie under the patellar tendon. There's Osgood-Schlatters condition, where in children that are developing very quickly, playing rapid or maybe over-involved in sports at a very young age, you'll see that the bottom of the knee is starting to become large and bulbous, and also your child will complain quite a bit of pain there. That's Osgood-Schlatters disease. It's an enthesopathy, which means that's the bone is not yet fused and the tendon's tugging on that bone. It's not strong enough to handle it, and so it reacts by growing outward. Another feature of the knee, the Baker cyst on the back side. On the back side of your knee is the joint capsule, and with repeated injury and repair cycles, the joint will be swollen and then heal, and swollen and heal. And over the course of a lifetime, some people will note pain in the back side of the knee. You'll feel it. It'll be a big swollen bag. The capsule blows out and fluids occupy the space, and they make for a very large bulbous feeling on the back side, usually the lateral side, which is the outside of the knee, on the back side there, and then you know you're dealing with a Baker cyst on that one. And the last thing I'd say about it would be the morphology of the knee. Knees tend to be pretty skinny when they're young and healthy. When those two bones, the femur and the tibia, are separated by nice, shock-absorbing cartilage, the meniscal cartilage, and the hyaline cartilage, which is the hard mother of pearl cartilage, the bones have no reason to change their shape. But as we age and some of that shock absorber goes away, you can just look at a knee and start to see that it's getting wider and wider, particularly the tibia plateau will just grow wider and wider. So oftentimes I can look at a knee without an x-ray and tell not only how much arthritis is being formed inside the joint line there without an x-ray, but how long it's been going on, depending on how wide the knee has grown, particularly when the other knee is in good shape and not arthritic, as an example of a comparison. So that's about all you need to know about the knee.